with fetal therapy and do the introduction, so I'll take over in her absence. But we have our genetic counseling students that are logged in. And just wanted to first say welcome back, Dr. Ruymann, from being away for a few months on maternity leave, and she's hitting it hard with her first fetal therapy back, and she'll be presenting on neural tube defects, which is so fitting because in the short few days that she's been back, she actually had seen a wide range in ultrasound. So take it away.
I know. Well, I was saying, so I picked this topic like back in September, and I was like, something that is high yield and very MFM. And then my first week back, as Stephanie said, we have a patient who is approaching viability, who she herself has had spina bifida. So we saw her, and then we had this case of anencephaly. So I said, the true millennial I am, I manifested it. But neural tube, yeah, exactly. Neural tube defects are a huge topic. But we're going to focus on some important points that I think we all should know. So just to touch on the embryology of the forming of the neural plate, and that's expressed by like watching videos. Like IU has some great videos that Dr. Ruymann has passed along to us. But the important thing for patients to know is that this formation happens before, even before patients know that they're pregnant. And that's a really important point for counseling. So at 3 to 4 weeks, you have a flat sheet of neuroepithelial cells that roll and fold in the midline to form the neural tube. And the closure starts at the cervical region and extends kind of cranially and caudally. The interesting thing is that this closure occurs in a discontinuous process. So it's not just like a linear formation, and it's very highly regulated and also not completely understood. And failure of closure in a certain location is what ends up happening in these different pathologies, which are mainly stratified by location. So you can think of two main categories as cranial malformations and spinal malformations, and this is kind of a highlight of some of the different types of pathologies that we'll touch on. So as far as epidemiology goes, the prevalence really ranges widely, and it really depends on regions. So within the US in the 2000s, the prevalence of anencephaly or acrenia, as we talked about earlier, is less than 1 per 10,000. And that's in live births, but just in births factoring in terminations and stillbirths in general, I remember about 2 to 3 per 10,000. That's for anencephaly. For spina bifida, it's more common, so about 4 to 5 per 10,000 live births, stillbirths, and terminations. As I said, the prevalence really ranges throughout the world. So in the Middle East, it can be as high as 20 per 10,000 births. And then by comparison, in the Pacific, more like 6 to 7 per 10,000 births. And this is really because of the different etiologies and different practices in regards to folate supplementation and also diagnosis. So the etiology in non-syndromic cases is multifactorial. There are genetic factors and environmental factors, and I'll just kind of touch on some interesting like medical trivia almost, but also some environmental factors. So the important thing to know is that these external influences must be present within the first 28 days of development. So these are things like before people even know they're pregnant. We've all heard people talk about how maternal hyperthermia can increase your risk. So this would be like hot tubs or saunas do increase your risk for neural tube defects, as do maternal fever. A very interesting environmental factor happened on the Texas-Mexico border in the 1990s. They had a neural tube cluster in a county in Texas, and they were using a fungal pesticide in And they didn't, so how this all got tipped off, I like went down a rabbit hole about this, and it's a really interesting story, but basically what happened in the 1990s, horses were getting leukomalacia and dying, and they linked it to a corn pesticide. And so they stopped feeding corn to all of these horses. However, it didn't get to the human consumption yet. So there were all these corn tortillas that were made with this corn crop, with this fungal pesticide that people ate that year.
Wow.
And there was a hospital that had 6 cases of anencephaly in 1 year, and that's what tipped them off. And then they did this study, and granted it was retrospective, but they would ask women how many tortillas they ate per day, and there was a correlation between like how much corn you were consuming.
Dose response.
A dose response of your risk of neural tube defect. Yep. And then that was removed from, they stopped using this fungal pesticide because of that. So some interesting medical trivia. There are also maternal medical conditions. We all know pre-gestational diabetes. That embryopathy has been definitively demonstrated in a mouse model as well. Maternal obesity, that's in our blurb in our counseling about having an increased risk of neural tube defects in obese women, specifically in women who have, that would be like class 2 and class 3 obesity. Also, we all know about treatment of seizure disorders, specifically valproic acid or valproate. The estimated risk is 1 to 2%, which is significantly higher than baseline. There are many genetic etiologies that are implicated, but many are multifactorial. Chromosomal abnormalities are common in fetuses with neural tube defects, up to 10%. The most common associated abnormalities are trisomies 2, 9, 12, 18, and 21. I think this should actually be a 13, sorry, it's probably a mistype. You also see trisomy 11 mosaicism and triploidy. You can see single gene disorders and chromosomal microdeletions in specific syndromes. So that's why doing genetic counseling, our panels for single gene disorders are very important here, as is even sometimes whole exome sequencing and microarray. There are hundreds of genes that are involved in this really astounding process, but there are genes that are specifically related to folate metabolism, the plantar cell polarity genes that are involved in how the neural tube moves during closure, and then also development of cilia, which is essential for cell signaling. So the MTHFR gene mutation has been an area of study and interest. It encodes a cytoplasmic enzyme that helps convert homocysteine to methionine, and mutations in this gene are associated with higher frequency of neural tube defects. However, it's sometimes you see a higher neural tube defect, but sometimes that isn't also true. So therefore, routine screening is not currently used. Along with the folate acid metabolism, we all know about folic acid supplementation, and this is
Good morning.
basic, but it also necessitates.
I
that we-
reviewed your resume on Indeed, and I was hoping to have a minute to chat with you. Do you have a few minutes?
Who's in control? Let me see if I can check. There we go. Thank you. So for folic acid supplementation for the general population, we're looking at 400 micrograms of folate daily, 1 month before pregnancy through the first 12 weeks is the essential time. For high risk groups, so people with a history, partner history, or children, if you've had a child who has an open neural tube defect or taking seizure medications, you should be on 4,000 micrograms daily, and that's 3 months before pregnancy and through 12 weeks. So the time period is longer. There's a delay on my internet. So the data that comes from this is there was the Medical Research Council vitamin study was in 1991, and they took almost 2,000 women who had previously had a child with a neural tube defect, and they looked at folic acid, other vitamins, both or neither. And they showed that this higher dose of folate before pregnancy through 12 weeks had a 72% risk reduction in neural tube defects. And shortly thereafter, in 1992, was the first recommendations from different societies regarding folic acid supplementation. And then it wasn't until 1998 that the US started mandatory fortification of wheat flour with folate. And since then, it's been estimated that maybe even up to 50% of NTDs have been prevented by folic acid supplementation. And recent cases have shown almost an 80% reduction risk in spina bifida and almost a 50% reduction risk in anencephaly with higher doses of folate in high risk groups. So very important, and also something that is important for counseling, especially preconception for patients. So kind of things that I talked about, estimated that up 50% of NTDs could be prevented with folic acid supplementation in the general population. And as I talked about, general numbers to think about 70% in high risk groups. And those are the people that we should be highlighting. In addition, people on seizure medication. So this highlights importance of things to talk to people about at postpartum visits or in preconception visits. I feel like sometimes by the time someone gets to us, the neural tube, what's done is done. So really highlighting preconception counseling.
What about twins and patients with sickle cell anemia? Would those be ones that require 4 milligrams or?
I don't know. I don't.
Probably not recommended.
Recommendation.
Yeah, I've ever read. You know, it's a good idea, but I've never read.
It's not
The one
recommendation
thing that
for twins, but there is a recommendation for sickle cell disease or any other medications that will affect folic acid metabolism.
Wait, sorry, Amanda, couldn't hear you very well. What did you say?
That for a folic acid, there is no recommendation for twins, but for sickle cell disease, there is increased dose, and for any other medications that may affect the folic acid metabolism.
Yeah. Katie, remember, did we go down a rabbit hole about, do you remember that?
she was on like carbamazepine for
Yes.
bipolar disorder, and how like there's some thought, if I remember correctly, about increased folate like affecting mood changes,
Yeah.
and we did go down a rabbit hole.
Yeah, I think we decided on 1 milligram instead
Yeah,
of-
we did
yeah.
decide on one. Yeah.
Anyway, sorry.
The other thing that can come up, which I didn't go in deep, but for some patients with pernicious anemia, there's been thoughts that you shouldn't be on higher folic acid, but actually what I was reading is that that's not true. I've never seen a pregnant woman with pernicious anemia, but if it comes up. So patients will ask, is it safe? It's a non-toxic at very high doses, it's water soluble, so they excrete it in the urine. As I talked about, masking pernicious anemia isn't actually a problem, and there is no association with increased risk of twinning. I guess that was a concern at a previous time. Kind of like a practical note, so actual application of this, most over-the-counter prenatal vitamins have the baseline dose. It's really important to tell patients not to just take more of the prenatal, and that's specifically because of the vitamin A. It at higher doses can be teratogenic, and some prenatals have your max dose of vitamin A. There are folate resistant NTDs, as we talked about, environmental exposures, maternal diseases, genetic disorders. And interestingly, even though women who are on valproic acid are recommended to have 4 milligrams of folic acid, the benefit isn't entirely definitive. And the thought is that valproic acid may be like a non-folate pathway, but regardless. As far as family history risk for fetuses with NTD, if you have an affected sibling, your risk is 3%, 2 siblings, 10%, a second degree relative less than 1, and a third relative is basically much less than 1. But things for counseling, especially to ask about prior history.
Just FYI, as a switch topic, it's impressive that this folic acid supplementation is actually based on randomized trials, and they're very, very large ones because 1 in 10,000, even 10 in 10,000, very hard to do. But many years ago, 30, 40 years ago, very large multi-center global randomized studies were done. So 400 microgram is really the evidence-based dose that almost all of this 2, 3, 4, I don't know exact number randomized study used. Everything else, carbamazepine you brought up, history of prior, etc. The rest, it's less based on level 1 evidence. But if you think about it, like group bistrep, things that are not that common, many times we don't have randomized studies for this. I don't know how they did it, but
Yeah.
there are really huge randomized studies that changed practice, and that's when we started. And there's a whole another thing, I don't think you probably over this. Another very discussed issue is how much to supplement, your food. And you probably don't have any more slides on that.
No.
Yeah, but we supplement, our red wheat,
yeah.
whatever. Many countries do not, and you wonder why. I think that England and Ireland, where the incidence is higher, or Middle East, etc.
Yeah, exactly.
They should probably supplement even more than we do, but many don't. It's even interesting on a public health point of view, because like you say, 50% take folic acid, you prevent them.
I know, it's pretty wild. Also, for me, it's like the fact that they didn't start that until 1998.
Right.
It's wild.
Yeah. It's relatively recent.
I remember looking at the
box.
Yeah.
Have pregnancy or unplanned,
Right.
even at the
All
best
of
of
that.
places, within 20 days, you're not gonna know if you're pregnant or not. So that's why putting it in food or whatever, I think it's the way forward.
Yeah, putting in Honey Nut Cheerios.
Yeah.
And for our screening that we do every day, just basic things that are good to refresh. MSAFP is a maternal serum alpha fetal protein. It's a glycoprotein that is secreted by the fetal yolk sac and liver. It's reported in multiples of the median, and that's compared to unaffected pregnancies at the same gestational age. So it's a reference range. The detection rate for MSAFP greater than 2.5 multiples of the median for anencephaly is 95%, for open neural tube defects up to 80%, but there is a false positive rate of 1 to 3%, which is pretty high. And we see this a lot in the ultrasound unit when we're counseling patients on elevated MSAFP. There are reasons you can have elevated MSAFP: inaccurate dating, multiple gestation, abdominal wall defects, kidney disease, fetal demise, and placental abnormalities. And then there's a calculator adjustment for patients who are diabetic patients. So for ultrasound screening, there's a higher detection rate through ultrasound than with MSAFP alone. The detection rate for neural tube defects has been reported as greater than 95% by a second trimester ultrasound that's between 18 and 22 weeks. It is possible to detect on a first trimester ultrasound, but that's not a substitution to getting a detailed anatomy, and MRI is not recommended for primary screening. So this comes up a lot of times when you're counseling patients, like how reassured are we by a normal ultrasound? And in skilled hands, very reassured.
And I'm sorry to interrupt, but I think it's easier to make it interactive. And I'm sorry Huda is not here because I know she feels a little bit different on this. There are many countries in which a second trimester FP is not done anymore.
Yeah.
Many, France, Italy for sure, many other ones. And it's because of what you have on your screen.
Yeah.
Assuming that everybody's going to have an anatomy scan, you're probably going to detect it there. Just FYI, we keep on doing it. I just,
Yeah, and
mixed feelings, it's another blood draw. There's a lot of false positives.
yeah.
Now that we have really good machine, in a place like us, that is good machines, great sonographers, are fully good at reviewing images, etc. We come back, for spine, things, all of that. I mean, I can't remember an NTD we missed in the recent memory. Like, I'm just thinking, obviously, we don't have that many, just because 3,000 deliveries, we're not going to have too many NTDs, even over 20, 30 years.
So it's clear though that, because I remember Neil and I were looking at this, or Neil, I remember mentioned working with Rodney, like it's clear that their ultrasound is better. Is that true? Like,
I'm not sure it's better. What I remember is that both have a 95% plus detection rate. Protein does, but there's a lot of false positive, and an ultrasound does.
Does having
I
that
believe,
prior kind of like, give you a little bit, like,
Yeah.
maybe there's some bias in that, like, if there is an elevated AFP, then you're more likely. to
Right,
know.
right. I don't know.
Another
And
question.
I must admit, I don't know all this data. Stephanie?
yeah, another question I wanted to pose to you guys, is kind of going outside of just for evaluating open neural tube defects, is there value, like for you as the MFMs, is there still value in the MSAFP screening, especially in cases where it's more likely to be possibly due to like placental insufficiency? I know that we do in those cases generally recommend like a third trimester fetal weight just to check the growth of the baby, but do you guys find that there's still value in the MSAFP screening whereas you mentioned other countries are pretty much fully relying on ultrasound alone?
I think there's been reported associations between adverse perinatal outcomes, but whether or not our interventions reduce that risk, I'm not sure. I think it's not an indication for NSTs. It's not an indication for technically like really the growth surveillance, although I know some places do that.
I think we're
And there
still
was
doing
even-
it for the NTD. We're not doing it for
The
the
placental
false
impact.
positive.
Right.
I mean, fibroid can increase on FB, so many things can increase FB. The list is like over 100 things that can falsely.
But I think also something to think about is MSAFP, if done properly early on, potentially might get you that
ultrasound done earlier. Yeah, like a 16-week
Yeah.
MSAFP, yeah.
Right? But that's,
Sure.
but again, in a patient population where obesity is very prevalent and, this can be difficult, to that type of utility. But there was even a letter that was published in the Pink recently on just like how there's a lot of inconsistent use.
Yeah. And a lot of people that, I think the letter in the Pink say that a lot of places like ours that still do it, actually only, I forgot which place it was only like 60-70% of the time you do it because you just forget,
It was at Brown.
Okay.
Yeah, and I think also like for me, it's also the patient part of it. I think it causes, there is a lot of like anxiety and testing and things that come from a falsely elevated MSAFP. But then they do get some reassurance with a normal second trimester ultrasound, but if it's not adding to what we do, who knows what will happen in the future. But a lot of food for thought with MSAFP. Now I'm going to go into kind of more the anatomical abnormalities that we see as part of neural tube defects. So focusing on the cranial abnormalities, exencephaly is failure of scalp and skull formation. And so you're going to see that the brain is now exteriorized, and this is kind of a precursor to anencephaly, and you kind of think of this as a sequence. So with that, you're going to see wide and irregularly shaped head, and I'll show pictures. You're going to see no echogenic calvarium surrounding the brain, and you're going to have a size date discrepancy and a well-dated pregnancy. So for this is what we would have seen with our other patient if we had scanned her earlier. And this, you'll see in the sagittal plane that the head appears flat and irregular. And you can see this Mickey Mouse sign they call, which is in the coronal plane. So this is a coronal image. This is the fetal face here. You see those are the cerebral hemispheres that are displaced. And that's called the Mickey Mouse sign, and 3D imaging can be really helpful with this. So then what happens is basically you progress to anencephaly because the amniotic fluid starts breaking down the fetal brain tissue. So again, this is caused by failure of fusion of the cephalic portions of the neural tube. So you're going to have absence of brain, skin, and skull. And you're going to see, like we saw in those other pictures, basically like the calvarium isn't there. You're going to see normal appearing orbits, but they're going to look pretty prominent. And you may see some disorganized brain. And then the amniotic fluid will appear more echogenic, and I'll show pictures of that because as you're having neural tissue that's broken down. And then you can also have polyhydramnios because babies can have irregular swallowing. So here are some pictures of a baby with anencephaly later in gestation, and this is the disorganized brain tissue here. And then this picture, you can see this is really interesting. This was a twin gestation, and this is the second sac, which is the normal anechoic amniotic fluid. And here in this baby with anencephaly, the amniotic fluid is more echogenic. It almost looks like dermoid, like that snowstorm appearance on amniotic sac. So this is a sequence of events, and it's helpful to kind of think about that when you're talking with patients. So at first you have failure of the neural, you have the neural tube failure, then you have exencephaly, and then the exposed brain starts to disintegrate, and that's when you're seeing anencephaly. The differential, I feel like every differential now should always include amniotic bands. Like right before you started, we had some amniotic band syndrome cases. And so you can see anencephaly with that. Oftentimes you're going to see limb defects, but it should always be on your differential. Also, sometimes severe microcephaly can kind of look like exencephaly. But with that, you're going to see the echogenic calvarium. Other findings you might see are that partially developed forebrain that we saw in pictures. You're going to see the degenerating or exposed neural tissue. You may have abnormal facial features, ear abnormalities, cleft palate, as I talked about, polyhydramnios, and then high risk for stillbirth. And then, as we talked about, this is considered a lethal anomaly. Cephaloceles are a little different, but still neural tube defect within the cranial side of things. They're failure of complete skull formation, but they're kind of considered like a closed neural tube defect. Specifically, an encephalocele is when you have brain tissue that's through the herniation, and a meningocele is when just there's CSF in the sac. These prevalence is less than 1% per 10,000 births. You're going to get this thick skin covering over the membrane that I'll show you. And as I said, this is considered a closed neural tube defect. They're usually sporadic, and 80% are not associated with a genetic cause. However, there is a risk of recurrence, and if they're as part of Meckel-Gruber, there is even a higher recurrence rate because this is an autosomal recessive disorder. So things to think about with counseling, always important for genetic counseling and diagnostic testing. So on ultrasound with an encephalocele, you're going to see a sac-like structure adjoining the fetal head. The occipital lobes are most commonly in the sac, and the cerebellum is and you could see the cerebellum if the defect is low and posterior. So I'll show you what this looks like on ultrasound. So here you can see the posterior sac, and then you can see brain matter that is herniating within the cranial defect. So with this, like what will come up in ultrasound is you always want to make sure if you ever see like, oh, it's just a loop of cord by the spine or by the head, put color on to validate that. But that's, you can psych yourself out with these things sometimes.
Yeah.
And you can see how like in the wrong angle, that could totally look like a loop of cord. So that's something really important to know.
I think if you go back one slide.
Yeah, of
to
course.
that, maybe another point.
One more.
Yeah,
Yeah, here you go.
is, 12 weeks.
Yes, great.
So, probably gonna talk about it, but, we're talking about AFP at 15 or after. I mean, many of NTDs, as we do first trimester anatomy scans, we could detect.
Yeah.
Certainly the ones you've shown, anencephaly, cephalocele, lower NTDs. I think that's really what you guys are going to be doing most of your career.
No, first trimester anatomy is for
Right.
sure, 14 weeks.
And detecting these
Yeah.
way before and after. That's why alpha pros, I think, is going to die. Because
Because you'll see it beforehand.
and you cannot do an alpha pro before.
Yeah. That's a great point. Associated syndromes with encephaloceles are the trisomies. I remember just a little under 10% have chromosomal abnormalities. This is the big thing that we were talking about with single gene disorders listed there. A microarray won't pick up on those, so you have to send specific gene panel testing, and that's where genetic counseling really becomes important in these abnormalities. Did you want to add anything to that, Stephanie?
Yeah, and I mean, all of these generally are syndromic, so not, I can't say definitively, but most likely you'll see additional findings as well. Muscle-Gruber, sometimes you can see cystic kidneys, you can certainly see polydactyly or other hand anomalies, so guide the genetic testing as far as how far to take it potentially. So, and I know that oftentimes, and I don't want to steal your thunder, that potentially a lot of the times it's not due to an underlying genetic condition or syndrome. So it does kind of create it creates a thought process for us where it's like, okay, so how far do we take the testing in these cases? So, and usually in those cases, when we see other findings, it certainly makes us more suspicious of an underlying genetic etiology and possibly syndrome.
Thanks so much, Stephanie. Anencephaly, or if I'm mispronouncing that, is the defect is in the cervical and upper thoracic vertebra. So again, like named by location of the defect, you'll see an abnormally formed brain tissue, and you may see extreme retroflexion of the upper spine. So important when we're looking at our spine views. Other associated anomalies are going to be defects of the thoracic cage, also abnormal development of the diaphragm, lungs, and heart. Now more to the cranial defects. So spina bifida is a general term referring to the failure of fusion, or pardon me, of the caudal portion of the neural tube. Usually you're looking, usually it's 3 to 5 contiguous vertebrae that are involved. And then the prognosis and planning is really dependent on what is involved in the defect and also the location of the defect. But the most common areas in the lumbosacral region, which is why we focus on that, are really important when we're getting our spine views. So a meningocele is failure of fusion of the caudal portion of the tube, and that is just the meninges are exposed, versus a myelomeningocele, you're also having meninges and neural tube tissue exposed. Versus myeloschisis is no sac, and you just have exposed spinal cord and nerve roots, and this is more rare than the other two. So ultrasound findings with this, first of all, to focus on the bony vertebral findings, you're going to see splayed dorsal ossification centers on axial view. So this is when you're going down your transverse view of the spine. We always want our, the lamina to touch in almost like a pointy hat or like the forming of a roof, I kind of think about.
Okay.
So you're having like a tent coming down, and we always look for that versus what you'll see with that would make you more suspicious for a neural tube defect is instead of having like a point, they're gonna open like a V, and that would be abnormal. You can also then, so that's in the transverse view, and then if you're looking for like the sac, that's what you look for in the sagittal view. But that's why we do transverse and sagittal views of the spine. So that's here, like normally, right, when we look, and there's like a little drawing here. These should be like that. The lamina should be like this.
Like coming in.
Touching, yeah, or almost touching, yeah, coming in. And a lot of times people do a sweep and you can like follow it down. Other associated findings, this is where you can see basically you have this fluid-filled area within, or the fluid-filled cisterna magna is absent because everything is being pulled down. And that's where you see like your banana sign, which I show you, where the cerebellum is getting pulled down. So those are things to look in intracranial anatomy. You can also see ventriculomegaly, and that's something that they follow for prognosis as baby goes on in gestation. And also you can see as the brain tissues are herniating or being pulled down, you can see like the lemon sign that we've always learned in OB, where basically the skull is kind of coming in, but I think that's harder to see, and you can like psych yourself out with that. So here, the cerebellum, this is your like banana sign that you're seeing here. But again, like can be a non-specific finding, but if you see this, you should be start thinking like, yeah, are we looking at, is there an open spinal defect? Because this is your classic finding of the KRE2 malformation. So you want to really search for like, okay, is there a spinal defect that we haven't caught up? And also, did they get the MSAFP? Other associated things that you can see are agenesis of the corpus callosum. You can see scoliosis, so looking at like the curvature of the spine, club foot, other associated anomalies, rocker bottom feet with trisomies. 40% have additional anomalies. So like we always talked about, once you see one thing, you're searching for other things. The differential for spina bifida includes sacrococcygeal teratoma. So you have to kind of elucidate what is that sac-like mass. Is it the meninges that is outpouching? Is it an umbilical cord, or is it a teratoma? They'll be more complex appearing, and you won't see the brain findings if it's a mass. Or you shouldn't see the brain findings. You can have isolated scoliosis. So you're not seeing the brain findings with that, but you'll see like an abnormal structure or curvature of the spine. You're also thinking about body stock anomalies, or like we talked about with anencephaly, more amniotic band syndrome, things like that. So you want to look at, is there a disruption of the amnion? Are there other limb findings? So that helps with your differential. So the clinical consequences of spina bifida is like an entire week-long conference. But the big thing for us to know is that prognostic factors are so dependent on size, location, and also brain findings. So are we having progression to hydrocephalus? Prognosis is really variable, and it really is nuanced by what level is involved, how big the defect is, and is it operable, and where in gestational age are we catching this defect. So There can be impact on intelligence. There can be impact on ambulation, obviously. It's correlated by the level of the lesion and the muscle strength that is impacted by that lesion. Patients can have bowel and bladder function issues. Chronic neurogenic bladder can cause chronic kidney issues. And interestingly, babies can have a severe latex allergy with spina bifida. So it's important, and I don't know why that is, but it's important when you're thinking about like delivery purposes. I don't know why that is. Someone knows, I just don't know why. So our workup for any of these anomalies is always going to be genetic testing, diagnostic testing, further imaging, serial ultrasounds, and especially with spina bifida, we can refer to CHOP. They do myelomeningocele surgery there. So interdisciplinary work with certaers that do this work. Delivery planning deeply for neurological defects, their term delivery is preferred. There are earlier delivery is necessary in cases with fetal surgery, or if you have rapidly increasing ventricular megaly. As we talked about with anencephaly, breech presentation is more likely in cases of neural tube defects. It's thought that vaginal delivery does not adversely affect neonatal outcomes with spina bifida, but this is really dependent on like what has happened during their care previously, and also probably how large of a defect we're talking about. And then I told about my latex pearl. I just want to touch on one thing about kind of some like research history about fetal surgery when it comes to myelomeningoceles. The goal of fetal surgery to repair the lesion as early as possible to minimize damage to the spinal cord. And the first successful human fetal surgery for spina bifida was in 1998. The management of myelomeningocele RCT, the MOMS RCT, was published in 2011 in the New England Journal. And these were about 150 patients who underwent surgery, and in utero spina bifida closure was associated with lower incidence of composite outcome of fetal or neonatal death or need for a shunt, and that would be because of the development of hydrocephalus. And patients were more likely to walk without devices or orthotics. But there is maternal and fetal morbidity from fetal surgery, obviously need for C-section, infections, complications. And the point of this was not to go into fetal surgery, but there's fascinating videos out there if anyone wants to watch them, and a lot of them are performed at CHOP. So it's amazing that we have a referral center if we need patients to have that care. That is my presentation.
About the gestational age in which that happened, like what was the enrollment? Just talking about.
Yeah, I can look. I don't have that off the top of my head, but I have the reference for this. I don't know if anybody knows.
19 to 26 weeks.
For MOMS trial, I can look.
And, you know, if you look at, just to comment.
Considered obesity, I think, right? BMI greater
They have pretty strict criteria.
Really strict.
than diabetes.
Who qualifies for fetal surgery based on maternal morbidity.
And genetic testing too usually is required because if it is a part of an underlying genetic condition or syndrome, they may be excluded, I believe.
Yeah, so that everyone gets has to have an amnio, they have to exclude other genetic findings, that's to be the appropriate gestational age. But the point being, there is a gestational age at which surgery is optimally done, and so early referral is important because of the multiple workup steps before you even end up in surgery.
Right here. Yeah, so the fetal surgery happens prior to 26 weeks. Section, I have the exclusion criteria I'm looking at on clinicaltrials.gov. The BMI is 35. This is for mom's trial, right? Because it's ongoing.
Yeah.
Yeah.
No, that's
No, no,
done.
no,
It's
no,
been
no.
done. It's been done for a while now. They've had
But
multiple.
it was 35, the BMI.
I don't know that, I don't think they've changed their BMI. But,
But does that mean that other centers won't do the surgery for BMI?
so I usually don't, like, I would just refer someone who had an open neural tube defect because I'm not gonna decide if, you know, they will or won't get
Right,
surgery.
right,
And I
completely.
don't think it's possible for us to keep up to date on, you know, however they're changing, what their requirements are based on advancing equipment and, you know, comfort, et cetera.
Right.
Yeah. I know
But
also-
then, oh, sorry, go ahead, Rodney.
no, sorry.
I was just gonna say, the main point is that it is a tight gestational age window. Usually you're diagnosing this at the time of an anatomy scan, which for us is 20 to 22 weeks. So if there's, you know, we often have suboptimal spine views, but we're not really worried because you can see things well enough. You see a normal posterior fossa, you have a normal view, so it's like, whatever.
Yeah.
But importantly, if something looks like it might be abnormal, that is something that you really want to expedite that workup within, you know, under 24 weeks, so that, you know, if something's identified, you have time to refer them for an intervention if that's what's needed. Fetal MRI is pretty standard for that. It helps you identify the extent of the lesion. Again, for us, usually referring to CHOP, and they would do
that
that workup.
Isn't Adzik at CHOP? Like, isn't he? Yeah,
Yeah.
right? He's at the-
Yeah, he is CHOP.
The head.
Right.
Andrew, yeah.
Yeah. And then the other point I wanted to make, which you had mentioned, is, you know, you have associated anomalies, especially like it is common lumbosacral, but so one of the things you want to comment on is not just the way the limbs look, but that they're moving or not moving.
Yeah.
Because, you know, it just goes to function now. Now, like the exposure of amniotic fluid is not usually going to affect your neurologic function in utero. So it's not common that you're having like, you know, that you don't see legs moving, for example, because of neural tube defect. But it's just something that you would want to pay attention to. Everything looked like it's both physically looks normal, like the legs aren't deformed, and then that they're moving. And then so the mom's trial is old, and there are a number of long-term follow-up studies that have been done that continue to show improved various sort of quality of life and functional measures in patients who have gotten fetal surgery or open neural tube defect.
Great job. You're,
Huge.
I was just gonna
But I
say
thought it would
about
be
the-
helpful.
yeah, a couple of other comments, you know, going back to what we're just discussing, the fetal surgery. The main outcome that was different was the VP shunt. You know, the cumulative was death and over VP shunt, and death, et cetera, was the same, but VP shunt. So the question is, you know, is getting or not getting a VP shunt a big deal? There are other longer term outcomes. But it's also, you know, as a practitioner, if the baby has had surgery or not as a fetus. And, you know, there's questions, you know, was there some, you know, bias, you know, maybe places shunt less if she's had surgery versus not, et cetera. But we offer it, we should refer everyone. I think it's an ongoing, you know, issue. And I think as they get better equipment, better interventions, obviously the neurosurgeons usually, pediatric neurosurgeons does this part. I think they'll be, you know, they'll have better and better outcomes, but they also have, you know, a lot more preterm births, you know, needs for C-section, et cetera. So just to make a comment on that, which moms showed and other normal
Fetal
studies.
intervention.
Well,
Basically any open.
yeah, I mean, there are Achilles heel of fetal, you know, in neurosurgery. The other comment I was going to say that, you know, when I was in your shoes, you know, we used to basically section every NTD. Then there were studies that say that really doesn't make a difference. And one actually was by Donette Lewis, one of your predecessors here. And was one of the first times that we worked with Neumors, who was a, you know, spina bifida clinic, and she actually looked at those cases 15 years ago and published it in the Green, I believe, kind of, doing level of, like T4 over T8, L1, L5, the majority, S1, etc. And if you stratify by level, which is the most prognostic thing, like you say, Katie, looking at vaginal delivery, trial labors, etc., versus planned C-section didn't make a difference. And then after that, there are probably like 6-10 other studies similar to that showing no difference. And now it's certainly we have for over 10 years counseled, vaginal delivery. But I do think that, probably around the country, it may not be that way. And obviously, if they get more field therapy, then they'll get a section for that. But just to keep that in mind, I think that I don't think there's ever been a randomized study, but the data we have, perspective data is pretty consistent. That doesn't seem to be a difference. The vaginal delivery versus C-section.
I did find the guidelines.
CHOP, that's mostly C-section being.
I found the guidelines for their referral for CHOP.
yeah?
Here,
Oh,
I'll
cool.
screen share it.
Thank you.
It's, I mean, it is
Pretty
extensive. Folks can.
It is a high morbidity
Yeah,
procedure.
So- insulin-dependent pregestational diabetes, here they are. Like Stephanie said, any other fetal anomaly, cerclage, or documented history of cervical insufficiency.
The preterm birth.
Yeah, I mean, it's a lot that I wouldn't have thought of.
Yeah. BMI, oh, look, their BMI is 40 now.
Yeah.
That's interesting.
There's also one of the oral plenaries at SMFM. I think the number one abstract was subsequent pregnancy outcomes after.
After,
And it was like a similar, it was like a 10% rupture.
It's a high.
Right,
that's what
so
I'm
it's like
saying,
some other
high
classical-
morbidity
Yeah.
surgery.
They section at 37 weeks, I
Yeah.
think.
Mhm.
In subsequent, yeah,
Oh,
Yeah,
in
subsequent, yeah.
Yeah, it has like important implications for future pregnancy outcomes.
It was like a UK study, I think, or something.
That's fast. So treat it like a
Classical.
classical.
Yeah. I think one other thing that will be interesting is as we have, climate change and just general increase in like the Earth's temperatures, it'd be interesting to see if that leads to a change in incidence of these kinds of things. Obviously, like our body temperature isn't changing,
Yes.
but I don't know, it's just
I completely agree.
right. It's just like our entire environment is
Yeah.
changing by degrees, and is that
I think eventually it's gonna be when like we're ready to retire, Kavisha, but it'll be like environmental obstetrics,
Right.
I think is gonna be the next wave.
Yeah, I know it
already gets.
it is,
but-
people are definitely looking at it.
Yeah.
Important. Because these are like really like population level changes that you would see over time.
Yeah, no, it's a fascinating topic. Thanks, guys.
That was the risk of open repair and subsequent pregnancy was not 10%.